What hurts us, and what I want to talk about today, is what has happened with our insurance industry. You know, insurance, the whole concept of making insurance available for people was that all populations, whether you're sick or not, would pay into a program, and basically the people who are sicker are the ones who benefit. Younger people now pay in, and guess who usually generally uses the benefit are older individuals. And that's what has worked out for a long, long time. Sadly enough, with many institutions that get created by government, abuse occurs. And I'll talk about two, primarily with pharmacy benefit managers, but I really want to talk about Medicare Advantage. We worked a lot on the physician fee schedule last session. The work is not done, but we actually were a good place and actually have a good partner now at CMS that understands that we can't keep killing our physician payments because it's driving people out of practice, period. And we have such a shortage of doctors now. But what we're facing now with Medicare Advantage, which was started, I think, in 1997, and then modernized, quote, in 2003 and then 2010, is a good system. It is a capitated system that was supposed to be 95% of what, quote, fee-for-service Medicare is supposed to be. And what it does is a company will pull an enrollee. You guys have seen the commercials with Joe Namath and JJ pulling people in. You'll pull in an enrollee, and they'll be paid by Medicare capitated payment and deliver a bunch of services for the patient. It's supposed to be something that helps keep people out of the hospital, go into their homes, see what things are going on that could make them sicker, how to prevent diseases rather than just treatment. So in theory, it's an excellent practice. It really is. Yesterday in Ways and Means, we had several companies testify before us, all of whom actually do a very good job at it. They do a very, very good job at it. But sadly enough, as oftentimes occurs with programs, we have some bad apples. And let me explain what that has happened, why it's turned into a system that instead of costing 95% of fee-for-service, is now costing 120% of fee-for-service. Now, I believe it's 54% of Medicare enrollees now choose Medicare Advantage because of advertising, et cetera, et cetera. When you have these things called health assessments or risk assessments, when a nurse or somebody would go into a home, meet with the patient, an individual, and assess their health. And you can look at somebody. Well, if they have an arm that maybe had a stroke, they've had some type of issue. Sadly enough, that system has been manipulated, has been exploited, where we have several companies that now will go in and make a person appear much sicker than what they are. And I'll give you a few examples. If they're sicker than what they are, then they get to charge Medicare a lot more. There have been thousands of people who were, quote, diagnosed with HIV. So they got a higher boost from Medicare. The bad thing was they never had a blood test for HIV. They'd never been treated for HIV. We had 66,000 people treated for cataracts or diagnosed with cataracts. The sad thing was those people had already had cataract surgery. And the one that really kills me is most egregious. There's a very, very esoteric condition called secondary hyperaldosteronism. Mike would know that. I'm just a dumb urologist. We would never deal with that. It's very, very uncommon. Maybe 3% of the Medicare population. United Healthcare, and if you're here, I'm sorry. United Healthcare added that diagnosis to 3/4, 75% of their patients. And so they get an extra money for it. So I can give you multiple examples of why this is how this is occurring. And what is happening is we are losing hundreds of billions of dollars, in my opinion, fraudulently. That's medical malpractice, period, point blank. If you diagnose somebody with a disease that you've never treated or never diagnosed, and that's caused us to skyrocket the healthcare costs. We can't pay for this. We're running out of money. I think Medicare is what, in 6 years, 9 years, depending upon where we're going. So long and short, this is a bipartisan issue because we took a good government program, one that in theory really was going to work very, very well, and now we have people exploiting it. And those people, look, some companies now are under investigation by the DOJ. They've taken a good program and the honor of being able to help the healthcare delivery of people, and they've exploited their position. So I'm very vocal about this. And we can get into the denials. Poor Mike and I having to get denied. I don't know if any of y'all have ever had anything denied. Anybody ever had that? I have a medicine I have to take because I don't have a pituitary gland anymore, and I'll end with this. My endocrinologist prescribed it for me last summer. I have gone through 8 denials till I finally have gotten it. I finally had to write the ombudsman here in Washington, D.C. to get the medicine. 8. And I could have probably picked up the phone as a member of Congress and maybe pushed it out, but I wanted to see what the average person would go through. I don't think the average person would have gone through this. And so we have to reform an industry that has gotten out of control. And we want to have willing partners. They actually came to CMS and HHS a few weeks ago and said, we're going to reform ourselves. The proof's going to be in the pudding. Anyway, I'll leave it at that. That's 5 minutes. So, Mike?
Thanks. It's an honor and a privilege to be here with you. I wasn't aware that you were having these meetings until I got invited, and it's always a pleasure to be with Dr. Murphy. He's an amazing fellow, and John Joyce, the co-chair of the Doc Caucus. These are distinguished, honorable people who have actually brought me and other freshmen like me under their wings to help us, and I'm really appreciative of that. This is a dangerous place. There's a lot of interesting things that happen here, and to have people, and I'll include you in that, and I'd love to have your help wherever you can, is that to have people that are willing to teach you where the landmines are and where the boa constrictors reside so that I can avoid the strangulation that might come along with certain actions. I'm a big fan of prevention. That's why I went into family doctoring, because I want to try to avoid problems and help my patients avoid problems. So Greg's comments, and Jim, thanks so much for having me here today too. That was really nice for the invite. But Greg's comments are a very interesting lead into what I wanted to talk about, and that's, so I carry multiple hats. Of course, I'm a husband and a father, and my wife and I love our children, and we have 10 grandchildren. The most recent was born just a few weeks ago, and it's a thrill to have that aspect of my life. But I'm also an attorney and a doctor, and the legal profession and the medical profession, I'm very interested in these ancient and both noble professions. We make fun of attorneys, and we should, and I'm good with that. But at the same point, attorneys, for thousands of years, every society has had some version of legal interpreter, a judge or an attorney. And for thousands of years, countless times, since humans have been walking around and organizing, they've had doctors, some kind of medical practitioner in whatever fashion. We've not always had a cell phone creator. We've not always had the electronics, the transmission of electricity, and so on. But you can think about the fact that attorneys and doctors have been, they're as ancient of a profession as I can imagine. And then I think about the privilege that I have of bearing both of those and thinking about, so I went to 3 years of law school. I went to 4 years of medical school. 3 years of law school, and you can go out and be a full-blown attorney. And in fact, during the 3 years of law school, during your summers, you can go and actually work. But your 4 years of medical school, which one of the things I'd offer to Greg is, why do we have 4 years of medical school? I'm just telling you right now, 80 or 100 years ago, somebody just said, hey, let's just make it 4 years. Yeah, well, if I was selling a product and I could have a consumer for 4 years at really extremely costly price instead of 3 years, I'd take a 4-year subscriber instead of a 3-year subscriber, right? And we both know, for example, that one of the aspects of the 4th year of medical school is it's all just, you can pick whatever classes you want. It's all kind of made up, and for a student, I thought it was great. I really enjoyed it, but I was paying extraordinary amounts of money for that 4th year, and I was also delaying a 4th year of an opportunity to earn professional income. My son is in law school right now, and he's working through the summer, and he's making some professional money. I was essentially worthless and couldn't make any money as a medical student until I graduated. I think, why is the attorney and doctor thing so different on that level? We have graduate medical education. I don't know if you know who pays for that. The taxpayers pay for graduate medical education. When Greg went to our residencies, and get this, he just mentioned Medicare is going insolvent, and guess what system is paying for graduate medical education? It's Medicare. It's like, who made that up? Like, why is the government so involved in this healthcare delivery process? Why is it we have it this way? It seems like every time we have a reform around Washington, D.C., we just take an idea and we hook it onto a program that already exists, even though it wasn't ever created. The program, Medicaid, for example, was never created to do many of the things that it's doing at this point. In this case, Medicare was not created to graduate medical educate, but we stuck it on somewhere in the past with Congress, and now the system's going insolvent. You think, is this a healthy way for us to go about this? The fact of the matter is, and I'll point out another really interesting history fact, is Medicaid and Medicare were created about 50 years ago, and we can argue about those kind of things, but there was an effort to have Medicaid for attorneys and for legal fees. There was an effort to do that, and the attorneys fought that tooth and nail, and they defeated it 50 years ago. It was smart. And the reason why the attorneys fought it and defeated Medicaid for legal fees was that they had already seen the first few years of Medicaid and what it was doing to doctors. And one of the points that I make about this place, there's 21 doctors in Congress based on the count that I have. There are 78 attorneys, and if you count full-time politicians and attorneys, that's 68% of Congress, whether you're talking Senate and the House, and we only have less than 4% that are doctors in Congress. So he and I could talk for all day as to why doctors don't want to be involved in this process. I mean, why would a doctor? He and I had great careers outside of this to come here and take the salary cut and the beatdown associated with this kind of work, when we can do great work with our patients. Like, it's a disincentive, whereas a lot of attorneys recognize how important it is to come here, and they come here and make this place work for them and their profession. So it's very interesting to think about, why is it that Medicaid and Medicare and insurance companies and now PBMs and hospital systems, why is it that they are the way that they are, and why is the government so deeply involved in one noble profession, medical profession, and not in the legal profession? In fact, I proposed that to somebody who ran a GME program, and the person responded by saying, well, life is on the line with healthcare. Well, it's a fair point, but if you've ever been sued, if you've ever had a legal challenge, your personal societal life can feel like it's on the line. Honestly, these lawsuits can ruin a business. And if you've never been sued, and I've been sued once as a doctor, I imagine Greg is too good to ever have been sued for over all of his years. But legal can feel like it's life-threatening. So the importance of medical versus legal, I won't use that, because I believe both of them are essential in our society. But one of the things that I bring to the table, and I'm very interested in long-term government reform, is why is it the legal thing is the way that it is, but the medical thing is so constrained and controlled by the government? And I think that's part of our problem, is we've really gotten our fingers into a noble profession that we could actually back out of on some level and ultimately help it to flourish instead of flounder. So I'm really grateful to be here and happy to take any questions that you have. But those are just some thoughts, and I'll just say to you, if you've got ideas on how we can reform. I'm working on some things that reduce opioid overdose deaths. I have a bill that we could talk about if we wanted to. There's a few proposals that I have, but I'm really focused on how do we make the system healthier so that it's working 50 years from now in a better way than it currently is. So thanks for your time, and happy to take the questions.
I know that you mentioned several priorities that you're both focused on, but given that we're finally past reconciliation for at least the first time, what do you view as potential items for getting across the line, either in a year-end package or sometime by the end of this Congress?
I'll just take the first snap at it. We have to have PBM reform. We have to have it. It was in last year's end of package, and some guy didn't understand that bills sometimes were more than 2 pages, and that got thrown out. We have to have pharmacy benefit manager reform. Again, good government systems try to control costs, but middlemen have destroyed it. And it is, in my opinion, probably the number one reason we have medications that are so expensive here in the United States. You know, the president put out the most favored nation status on pharmaceutical companies. I have to say I don't like that, and I've made that known to the White House. I think that's a club rather than a surgical approach to this, and I think it's actually going to hurt our industry. I think I'd like personally also for us to see MA reform that goes into long overdue bipartisan issue, and I think our insurance industries understand that they've gone too far. That's going to be important. Also, I'd like permanency as far as the physician fee schedule going. Mike hasn't had to deal with this, fortunately, but every year I had to go through this daggum cut, and then every year I was in practice, looking and saying, okay, how do we squeeze more out of already a dead turnip? Those are three very important things, healthcare reform wise. There are multiple other things that we would like to get included in the package, some wonky stuff with Medicare, fee schedule. But this is an avenue, and I think the speaker understands this, and I think committee chairs understand this also. This is an area rife for good bipartisan work.
PBM reform, it's really interesting to think about drug costs and why are they so expensive, and I'll just point out that it's a very constrained and controlled environment. The government's got its fingers in a lot of this. And you remember the $5 Walmart list of drugs? It's not that long ago. It was like 10, 12 years ago that Walmart actually had a published list of a lot of very useful drugs for $5. You could just go to Walmart with a prescription and get these drugs, a month's supply for $5. Where did that go? And I was talking with somebody yesterday about insulin. Insulin, we've known about insulin for 80 or 100 years. And we've been making NPH insulin and regular insulin for ages. Why is it that a prescription for insulin is so expensive? And the answer is big pharma is a big part of that, and PBMs are a big part of that. The reality is you change the molecule just a little bit, and you got a new patentable drug. In fact, I'll use the inhalant of albuterol, which is also, I mean, these are old drugs. You can get a $5 Walmart list, albuterol was on there. And you go to your pharmacy right now with an albuterol prescription for your asthma, it's going to be $80 for a month. And how did that happen? It's not inflation. It's more than that. It's PBMs, and it's people that are doctoring, in a bad way, doctoring up the molecule of the albuterol, turning it into something else. In fact, the propellant of albuterol, they used to use chlorofluorocarbons, CFCs, to propel the albuterol, and then we banned that, so then they put a new propellant in, and now albuterol is $80 instead of $5. It's like, this is a ripoff. It's all money driven, and PBMs have a lot to do with that, and I'm pretty irritated by all that stuff. Wherever I can reform on that, I'm certainly focused on it. Final thing I'll say on that is prior authorization reform, and Greg's totally right about the things he's pointing out. Prior auths are killing us. I'm paying my staff hours every day. I'm paying people to full-time be on the phone, fighting with insurance to get drugs that I've said we should have, and or I'm ordering the MRI because people we were talking at the table about possibly critical issues. I order MRIs or heart tests, stress thallium tests for people's heart attack sort of things, and the insurance practices medicine without a license. They refuse to pay for the tests that I've ordered, and they, I guess, have the right to do that. As an attorney, I think there should be more lawsuits against the insurance for practicing medicine without a license. But the prior auth thing is killing us. And frankly, I had a patient, this is 10 years ago for me, but I ordered a stress thallium. I was worried about this guy's heart status. And 13 days after I ordered, seriously, it was 13 days after I ordered the stress test on this guy for his heart that I got the rejection of that stress test. And on day 14, he had a critically life-threatening heart attack. It's like, well, I thought that, and that's my job. I spent 30 minutes with this guy, and you're reviewing my records, and you think that that's my record keeping is not sufficient to justify the stress test. I know insurances want to save money, but lives are on the line associated with that work. And I just say, my medical malpractice, I pay for that because I know bad things can happen when I make the wrong decisions. Why is it insurance companies are not subject to that as well? So this prior auth thing is a big deal. I'm sick and tired of taking my time to make decisions and subsequently having second guessing by bureaucrats and insurance companies to say, no, I'm not paying for that because I know better. I've reviewed your records, and they're not sufficient to justify this. That's a bunch of baloney, in my opinion. And frankly, we as patients, I'm warning you, your mothers, your fathers, you, if you go to the doctor's office, you're subject to that, and you better be aware. And frankly, we need, I'm the attorney, I'm putting up my attorney hat, is we need to file more lawsuits against these insurance companies for denying those sort of services.
Here, here. I will just add one other thing. Artificial intelligence. I think it's going to, good, bad, or indifferent, it's here. It's kind of like these damn cell phones. Wish we could get rid of those and go back to talking to one another again. But artificial intelligence, hopefully, will help with the denial process. But remember, it's only what you put into it that you get. And we've already seen some algorithms from insurance companies that have had such a high denial rate, which is absurd. It's going to change things. I think we were talking with Jay Bhattacharya at Docs Caucus last week. Artificial intelligence is going to change the world of research. because there's so much modeling that can be done. We may not have to use animal models again. We may get to a point where we don't need to do that. But it's going to revolutionize so much that goes not only in diagnosis, especially radiology, for example, mammography, or even some CAT scans. Radiology is pattern recognition, and you have to look at 10,000, 20,000 scans really to get an idea with that. Well, over a lifetime, maybe a mammographer may look at, I don't know, 100,000 scans. AI may look at 25 million scans and be able to pick things up. So there'll be some efficiencies with that, but we need them to occur in the world of insurance and not create such an absolute disaster debacle for the people just trying to deliver care to patients.
My question is about, you mentioned trying to avoid Medicare instability financially. I think a lot about side neutral payments and the potential for lowering Medicare spending over time. And I know in the recent OPPS, they included some site neutral payment provision for drug administration. I'm curious what you guys think the chances are of any sort of site neutral reform happening in statute over the next couple of years.
I think they're very good. I'm going to give you an example. When I ran our practice, if somebody came in with flank pain and I got a regular x-ray and I couldn't see a kidney stone, because that's oftentimes what we see, I'd get a CAT scan because that helps deter treatment. I can walk a patient literally 50 feet, get a CAT scan, know what I'm needing to, boom, it's done. That was $600. When I had resigned from my practice, my partners, because we had not gotten a paycheck for 3 out of the last 8 quarters because of Medicare fee cuts, got recruited by the hospital. I couldn't say don't do it because you actually get a paycheck. Now that CAT scan, not $600, is $2,800. It's the same damn machine in the same place. So these are abuses that they have, and you'll hear for hospitals say that, well, we take a lot more care of indigent pay and we have to have offset. And I get that. I was part of our administration for 3 years. I get that, but some of the egregious things that are occurring, that oncologists can't give therapeutic drugs in their office because they can't get paid for them, whereas someone would have to go to the hospital, get the same drug, and it costs 4 times as much. I'm going to give just a few sobering statistics about Medicare. 1965, average life expectancy was 70. Actually, in some men, it was actually lower than that. So you had 5 years. You were supposed to get it at 65, so we're all supposed to be dead at 70. There were 4.6 individuals paying in for each recipient then. All right, so you think about the pyramid. You had a lot more at the bottom paying in for just a few at the top. Let's get this 50 years. That number, that pyramid is not completely flipped, but it's turned almost into a rectangle, where it's 2.6 individuals paying for 1. So that's half the number of individuals paying in for this. And we're living longer. That delta now has gone from 70 to 80. That delta costs a lot more money, and we have 3% of people living into their 90s. So the math doesn't work. So I honestly, unless we raise the Medicare tax, which is probably what we're going to have to do, there's no way we can pay for this system.
You talked about a number of efforts that I think are very bipartisan in nature. And Congressman Kennedy, you mentioned opioid overdose reversal deaths and continuing to drive those down. Really appreciate that. And so would just love to hear a little bit more about what you're doing there. And of course, Congressman Murphy, if you have thoughts, would be eager to hear those as well.
Yeah, Narcan should be everywhere. One of the things about the opioid overdose crisis, and I lived through this, so my medical school was 94 to 98, and then I did residency 98 to 2001, 3 of the worst years of my life, but I'm glad those are over with. And one of the things around that time, I'm just going to go back to a common theme, is the government actually mandated pain is the 5th vital sign. Greg remembers this, and some of you are too young to know this, but pain is the 5th vital sign. They basically said the vital signs, including blood pressure and temperature and such like that, that we had to quantify pain on every patient. Sponsored by Purdue Pharmaceuticals. And that when, oh, you got a pain? Let me get you OxyContin. Seriously, I had fentanyl patches, Duragesic patches, the brand, that I had guys in the early 2000s coming to me, drug reps, to my office. I'm sure Greg had the same stuff. For back pain, you should give a fentanyl patch. A fentanyl patch. Like fentanyl's killing people now. And fentanyl's actually a great drug. We use it all the time in the hospital, but in certain doses. And I was giving out fentanyl patches because I thought I was just a dumb early doctor. Like, oh, they said it was good. And I had a patient come back, like, she said, I don't ever want to use that patch again. I almost couldn't. And so this nonsense of the government, in collusion with Purdue Pharmaceuticals, made pain the fifth vital sign, taught a bunch of doctors you got to give out opioids. We have a bunch of addicts, and then doctor cuts them off. They go to the street, they get their fentanyl, and they die from an overdose death. It's government collusion, stupid people doing stupid things. And so now we're on the responsive side, and it's going better. What I'm doing in my bill is opioid overdose deaths. You may know that the states have drug databases that they'll publish controlled substances on that database so that I can check before I prescribe what's on the database. Right now, substance abuse recovery drugs like methadone are not on that database, forbidden by federal law, that those drugs, because of the pejorative nature of them, that you can't put those drugs on the database. Well, my bill takes that ban off so that we can actually include. Why? Because I had a friend who's a state legislator in Utah who gave Xanax to a patient who was on methadone, a woman overdosed, young person, and she died as a result. And he brought this to me. I'm like, that's nonsense. Why do we have this ban on methadone and other drugs like that? And we found out together there was a law that banned that. So my bill is, I think it's a common sense solution. It's going to make more transparency for the doctor when they make that kind of decision to prescribe a controlled 2 and above drug. And so we're moving that through. Any ideas you have about how we can actually make it pass, we'd love to have your help there.
Mike was spot on. This whole thing began with Purdue Pharma. I think you have to look at the opioid issue as a three-legged stool. I've known, sadly enough, 9 young men, 2 in one family, that have overdosed. These were kids that went to school with my kids, church, scouts, all overdosed. And it's a three-legged stool. When I was in the State House, I had no idea why God opened that door for me to go into politics. But it was apparent for the next years because I wrote our state's opioid bill, something called the STOP Act. And this was basically to stop doctors from overprescribing. My orthopedic friends, buddies of mine, you go in for an arthroscopy, 90 Percocet. Yes. Whoa. You should get 6. If you ever had your tonsils, anybody have your tonsils taken out as an adult? Don't do it. My friend wrote me 86 Dilaudid. And I went, what? He goes, you'll need them. No, I didn't. And so I wrote the bill, and actually I wrote it, I think, back and forth literally 26 times to try to get different constituencies involved to say, look, you know what? Let's dial back. Let's not overprescribe. And that's really happened. I think, sadly enough, the pendulum may have swung a little bit too far. When I see kidney stone patients and they come in to see me in terrible, horrible pain, anybody have a kidney stone? Don't have one. But they've been given ibuprofen. That's ridiculous. And so you have to stop overprescribing. The other thing is I wrote something called the HOPE Act, which was to work with our law enforcement in trying to help gather this stuff. But the third leg is treatment. And without 3 legs on a stool, it falls over. And unless we do really something better about treatment in this country, because being an opioid addict changes your brain chemistry. It is a lifelong addiction that you have to treat lifelong. And so until we get all those things fixed, the Narcans, which have saved hundreds of thousands of lives across this country, only add days until your next overdose, a potential death. So,
it seems impossible that it was just 3 years ago, you all, every night we turn on the television and it's 100,000, it's 500,000, it's 1 million people have died from COVID. Are we over-vaccinated? It seems like Senator Kennedy, not to be confused with Congressman Kennedy or Dr. Kennedy, is now saying that we are over-vaccinated. From your standpoint, are we? And what happens in the future with so many things like measles vaccines or COVID vaccines for anybody over 60?
I'll just say this. We always ask ourselves, what's the purpose in prescribing a medicine? I tell my patients the best surgery is no surgery, the best medicine is no medicine. That's the best way you should do it. Why should you get vaccinated? If you are at risk to have a severe outcome from being exposed to a virus. And you have to, one thing we did not do, and I'm sorry, I'm going to be very plain about this. I think Anthony Fauci did the House of Medicine an absolute disservice in becoming so holistic about medicine. It was his way or the highway. We pushed vaccinations on people who were not at risk. And by the way, if you look at the data, Sweden didn't do that. Sweden didn't do that. Our per person mortality was almost 60% higher than what Sweden's turned out to be. So we became with the mantra of vaccinate everybody, which was wrong. If you look at the data, and I did this during the pandemic, if you look at the data, the incidence of severe myocarditis in the 18 to 35-year-old men was 4 times higher with vaccination than with COVID. If you were older, yes, you're at higher risk. If you were a child that had a comorbidity, yes. The CDC under Mandy Cohen came out with 6 months and older COVID. Absolutely ridiculous. Absolutely ridiculous. And you know, we were very big proponents of vaccination. We were, and I still am, for people at risk. Measles is one of the most infectious diseases with horrible things. Yes, I still believe that children should be vaccinated, but the whole COVID thing, I think, became very much about control. And they misused the House of Medicine. And I think we have a few people to blame for that.
It's a really interesting question. We could talk all day about this, and frankly, if you had us back to talk about this, we have an allergist attorney in the legislature now, Bob Onder, who's from Missouri. He's part of the Doc Caucus too, and he may have some comments on this. I had a master teacher in medical school. He said gluten enteropathy, which is celiac disease or gluten problems. He said this was in 1995. He said in 1995, gluten problems are rare, is what he said. That's laughable today. I mean, seriously, you go to the grocery store and there's a whole aisle dedicated to gluten-free products. It's everywhere. It's like fat-free used to be 30 or 40 years ago. So this guy's name was Dr. Lambert, and my question is was Dr. Lambert wrong? Or has something changed in the past 30 years? And that gets us to the immunization thing. The immunization schedule was a simple thing when I started 25 years ago. And now it's got 25 different vaccinations that people are supposed to get. And there's a new one every several months because there's a lot of money to be made in doing the vaccines, particularly the COVID vaccine. So I do have concerns that we're overexposing the immune system and subsequently translating that to other diseases. Rheumatoid arthritis. Matter of fact, if you want to scare yourself, go to Google or AI or whatever you're going to do and look up autoimmune-related diseases. And you will see from your hair down to your toenails a number of different diseases, and they're devastating. If you talk about Addison's disease through the adrenal glands, you talk about multiple sclerosis in the brain, you talk about rheumatoid arthritis, of course, asthma and allergies, heartburn, dry skin, eczema. The list goes on, devastating, deadly diseases and common conditions, and you think, what's going on with our immune system that we have so much of this gluten problem? I mean, I got all these people, they come to these meetings and you're gluten-free. You got all these dietary restrictions that a lot of people think. I don't think vaccines are the only possible question that we should ask. There's a bunch of GMO modified, I mean, the wheat that you consume, the corn, corn syrup is in everything we consume, soy and all that kind of stuff. There's a lot of strange things our bodies are exposed to today that 50 and 100 years ago they weren't exposed to. So laying that on the table and just being a questioning scientific sort of person, yeah, I do wonder if we're over-vaccinating people, subsequently translating the immune system, which if we keep beating on the immune system, it will start looking for things to attack. And it may attack your bones in the form of osteoporosis. It may attack your joints in the form of rheumatoid arthritis. It may attack your nerves in the form of multiple sclerosis. And you think, well, why is it getting so angry? It's like, well, we're beating on it all the time with various exposures, which can include, I mean, plastics. I had a plastics expert patient who was telling me, in this room right now, he was in our patient room that we had this encounter, there are microparticles, nanoparticles of plastics that you're breathing in pounds of plastics every several months. I'm like, that's disgusting. Exactly. And yeah, exactly. So I ask the questions. I don't have the answers exactly. I think a lot of research needs to be done, but our bodies are exposed to lots of weird things today that 100 years ago they were not.
Let me say 2 quick things. Number one, if anybody has not read Marty McCary's book, Blind Spots, I would actually recommend people read that. I was infuriated. I'm only halfway through it. Infuriated at the House of Medicine, some of the lies that we've been told. The peanut allergy, we created it. We created it. We should be giving our infants a little taste of peanut butter as soon as they started. And the whole American Academy of Pediatrics bought that hook, line, and sinker. I would really urge you to read that book. It's quite opening. Estrogen in females, cholesterol and fats. I will say one thing about vaccines here. And I got the shingles vaccine a year or 2 ago, and there's good evidence out of Japan that actually causes a 20% decrease in dementia. So, sometimes drugs have good side effects. That's going to be interesting. But to Mike's point, it's all about what's indicated, what's not indicated, who's at risk, who's not at risk.